Good afternoon, everyone. My name is Patricia Noga, and I'm the Vice President of Clinical Affairs at the Massachusetts Health and Hospital Association. I want to welcome you to today's webinar, the PSSM, Patient Safety Structural Measure. A few logistics before we start. If you have questions during the webinar, please enter them into the chat feature as we are in listen-only mode. The questions will come directly to us, and we will do our best to address as many as we can at the end of the presentation. I also want to take a moment now to thank MHA's 2025 annual sponsors and strategic partners for their support in underwriting today's webinar, which is just one of the many events we have to offer throughout the year to connect our members with leading experts to help address timely issues like the one today. Now moving on to our program. In August 2024, CMS introduced the Patient Safety Structural Measure, or PSSM, for acute care hospitals participating in the Hospital Inpatient Quality Reporting and PPS exempt cancer hospital quality reporting programs. It has been recognized that a systems-based approach to reducing patient harm is necessary within the complex healthcare ecosystem. The PSSM assesses how well hospitals have implemented strategies and practices to strengthen systems for safety. So with that brief introduction to the PSSM, I'm pleased to introduce our speaker today from the Institute for Healthcare Improvement. Patricia McGaffigan is the Senior Advisor for Patient and Workforce Safety at the Institute for Healthcare Improvement and President of the Certification Board for Professionals in Patient Safety. She previously served as COO and Senior VP of Safety Programs at the National Patient Safety Foundation. Patricia is a certified professional in patient safety and on a number of multiple advisory committees, including the Joint Commission National Patient Safety Committee. She serves on the boards of the Massachusetts Coalition for the Prevention of Medical Errors and Plaintree's Person-Centered Certification Committee. Thank you for being here today as we are looking forward to this discussion. I will hand it over to Patricia to get us started.
Thank you, Pat, and welcome everyone to our webinar today. It is my delight to be a part of this very important opportunity to catch you up on timely events in patient safety. And I'm going to just take a moment here to get my screen set up. As we talk today, we are going to be inviting you to respond to some polling questions about the patient safety structural measure and welcome your participation to help us get level set with where things currently stand in your organization. So I'm just going to take a moment here to check Nick and see if this screen is looking good for all of the colleagues who are with us today.
Not yet. We just need to swap it over.
Not yet. Okay, so I need to, can you see my screen?
Yep.
Okay, and I just need to do the switch.
Yes.
Which, by the way, colleagues, we have practiced on a few occasions here, and always helps just to do that double check. So I think we're in good shape at the moment. Is that correct, Nick?
Looks good.
All right. So thank you so much, Pat. Thank you for the warm welcome, and I also wanted to acknowledge that over many years, I felt very grateful to be living in the state of Massachusetts, which is where I know many of you are from, not everyone, and we welcome you from outside of the state to this important discussion. I also know that I am surrounded by people who are incredibly passionate about safety and who have been at the helm of anchoring safety in the daily work of the enterprises in which you work. To get started, I just want to share a few disclosures. I will not be discussing the one that you see on the screen here about my board role. However, I do want to disclose that while I'm very, very close to the patient safety structural measure and have worked on some of the seed work that informed the patient safety structural measure, I don't work for CMS, and I'm not, a qualified standards interpreter when it comes to some of the questions that might come up today. However, I also know that there are many of you on the call today that may have some experience with the patient safety structural measure, and I invite you to jump on in with perspectives that will enable us to deeply understand where your expertise might be helpful to build the blocks for others who are on the call today. It's our goal today to take you through an appreciation of what the PSSM is about, to Pat's point, in terms of fortifying the systems for safety, to give you a glimpse of what some of the elements within each of the 5 domains are about, and to also open up some avenues and opportunities for structuring your assessment process, particularly with one tool that might be especially helpful as you embark on your preparation and advancement of safety in alignment with the structural measure. But before we begin, we'd love for you to pull out your phones and help us get level set in where you stand right now. The first question is about your familiarity with the structural measure. And for some of you, it may be the first time you're hearing about it, or you may have heard about it, but you don't have a whole lot of context. Others of you on this call are probably more advanced in your journey to socialize the importance and the focus of the patient safety structural measure, and may already be comparing in your organizations where you currently stand in relation to the elements of the measure itself. So and a few of you may not have direct relevance for the measure. So let's see if we can line up. Great. Hopefully you can see the rapidly moving bars on this. We've got a small percent of you, but a very important percent who are hearing about it for the first time, or may have heard about it and may not know a lot. Grateful to see that almost half of you have begun to socialize this in your organization or are on a journey conducting an assessment. So that's all good news, especially given the time sensitivities around this measure. The next question is asking what tools, if any, you might be using to assess alignment of your organization with the structural measure. Some of you may just have developed, for example, an Excel file where you're comparing what's in the measure with what you're currently doing. Others may be using a tool that we'll talk about a little bit more today that is well aligned with the patient safety structural measure. And some of you may, again, also not have immediate applicability or direct responsibilities for the measure, or you may be a little bit unsure at this time. So we are looking at, we were looking at about an even split across a few of the elements or a few of the options you could have responded to. Some of you developing your own tools. Some that are using the National Action Plan Assessment Tool, and a little bit of uncertainty out there if you're not immediately involved in this work in your organization. So let me just take you to the third of 4 polling questions that we're going to ask about today. And this one is exploring your familiarity with the Safer Together organizational assessment tool. Maybe again, news to you, or it may be something that you're much more familiar with. Some of you are already using it in your organizations. And because it has more direct applicability for the content of the structural measure and is freely available, we wanted to really see where your current state might be. So more who are hearing about it for the first time, and some of you who are using it right now or exploring it, and good to see that 11% of you are kind of well on your way on this front. So thank you for that level setting, and I can't see the chat, so as comments come in, I know that the amazing team at MHA will be tracking those, and we will be opening up a lot of opportunity for discussion a bit later in our webinar. Let me start with a little bit of review about structural measures. And many of you may be familiar with the Donabedian framework for measuring care quality, which is including structure, process, and outcomes measures. And others may also be aware of this notion of balancing measures, which are often used when we're testing an intervention. But the bottom line here is that structural measures in general are looking at whether we're ultimately setting ourselves up for success to be able to accomplish a goal. And in this case, the systems that are important for safety to be realized in the everyday work of healthcare. Structural measures are not new from CMS. There have been several that have been in place for a few years now. They started off primarily in the space of maternal safety, asking hospitals one question about whether or not they were participating in perinatal safety improvement collaboratives, and that has expanded into the 2024 measure that leads to public designation of birthing-friendly hospitals. We've had structural measures associated with health equity and social determinants of health that were hospital-based that have now expanded beyond the hospital setting. And as Pat noted, in August of this year, when the final rule was announced for this new year, there were two new structural measures that were added, one being the one that we'll focus on today, and another one that is on age-friendly related practices. So I just want to note that in many of your organizations, you may be working on both of these measures at the same time. A little bit about the patient safety structural measure is that it is applicable to acute care hospitals that are part of the inpatient quality reporting program, and as Pat noted, cancer hospitals that qualify under the PPS exempt designation. And I know we've got one in our immediate backyard here that falls into this category in Massachusetts. This is a measure that is about what hospitals attest to doing. And again, it is meant to ensure that we've got the work and going on and the structures in place to advance safety from a systems lens. I did want to note that about 5 years ago, we released the Safer Together National Action Plan for Patient Safety. This was the first public-private created national action plan for safety in this country. And the American Hospital Association is one of the members of the National Steering Committee that developed this plan. At the onset, we had 27 members in total, including federal agencies, patient and family advocates, safety experts, health system leaders, and more that came together to shape this national action plan. And in the intervening years since it was released, CMS became more interested in thinking about a structural measure that was largely informed by the National Action Plan and also built out through the expertise of a panel of 18 diverse representatives, again, including patient safety and quality experts, health system leaders, and patient and family advocates. This measure went through 2 public comments periods before it came finalized in the final rule. In this measure, there are 5 domains that have 5 elements or statements within each of the domains. And hospitals are asked to attest to whether or not they can affirmatively respond yes to each of the elements within a domain. If so, hospitals will get a point for that domain, and there are no partial points awarded. So if you get 2 or 3 of the 5 elements within a domain, you cannot get a point for that domain. Therefore, the scores can range from 0, meaning for across all 5 of these domains, I cannot affirmatively attest to each of the elements, to a high score of 5. There are no penalties or payment implications for applicable hospitals if you respond no to the statements or if your score is a 0 or is a 5. The initial reporting period began in January of this year, which is why MHA, really wanted to make sure that we were offering this opportunity to get more, aware of the structural measure. And the reporting period ends at the end of the calendar year. The first reports, meaning the first attestations by hospitals, are due to occur in spring of 2026. The scores will be publicly reported on Care Compare beginning in October 26. And at that same time, which is the start of the new fiscal year 27 for the federal year, any hospitals that fail to report will face reductions in their annual Medicare payment updates. So there is, a penalty in place if you do not report. There is not a financial penalty in place if you do report, regardless of your score. However, that public visibility of the scores provides an incentive for organizations to think carefully, both for the consumers who are looking for healthcare organizations that they want to receive their care at, and also for employees that are curious to work in organizations where they know there's a deep commitment to patient safety. The structural measure itself came into place much as the National Action Plan did, because, well, we've made really important progress in patient safety. And I want to commend those of you who are on the call today, because I know it's your daily work that has really helped us come out of the gates since 1999, 25 years ago, when To Err is Human was published, with these performance improvements, which have been notable. Yet what we have found very broadly, and a number of studies have revealed, that there's been uneven progress that's been achieved in hospitals. And we do know that despite the solid commitments of many organizations to patient safety, amid the understandable challenges of COVID, we saw a lot of setbacks in performance, which, by the way, now on a good news note, are being reversed. And we're beginning to approach what we might consider pre-pandemic levels of performance in patient safety. Yet, I think our patients would tell us, and many of us know, that we still have opportunities to go. Much of the work that we have focused in on in patient safety has centered in many organizations, almost sometimes disproportionately, on what happens at the sharp end of care, and whether we are employing evidence-based practices, at the care provider level to help mitigate the risk of harm. And yet, when we look at what organizations have been doing very broadly, we have seen a little bit less of that attention to the strategic and the operational practices that we know are foundational and necessary for safety. So this is kind of what, again, prompted the nudge toward patient safety structural measure. The measure itself, and I'll just move on to the next slide and jump on in. For those of you who are familiar with the domains, the 5 domains which are listed on the left, I just want to take a moment to describe the intent of the domains, particularly for colleagues on the webinar who may be hearing about the structural measure for the first time. So in the first domain of leadership commitment, what we're really looking at here is the focus of how the senior leaders and boards address the importance of safety, how they set the tone, and what is happening at that level for essential leadership practices for safety. The second domain around strategic planning and organizational policy is evaluating and attempting to help hospitals really think about how they use the strategic planning cycles and internal policies to realize this demonstrated commitment to safety. The third area is around culture of safety in the learning system, looking at whether hospitals are integrating evidence-based practices and protocols that we know are fundamental for safety cultures, and learning systems. And this is where I think it's just important to keep in mind, not only within hospitals, but across hospitals. The fourth area is addressing two key cornerstones for safety, and that focuses on accountability for outcomes and transparency of safety events and reporting. And the fifth area is around patient and family engagement. Not only are we supporting and advancing the meaningful engagement of patients and families in their own care, but also in the co-production of safe systems. So what I'd like to do now is walk through the 5 domains, give you a little bit more perspective of the different statements that fall within each of the domains, and kind of set the stage again for what this might mean for your work, especially if your organization is, will have patient safety structural measure elements that are required on the basis of whether you're participating in the IQR program. Under leadership commitment to eliminating safety, there are, again, 5 statements or elements. And in order, again, to get a point for this domain or any of the other domains, your hospital would attest that they can affirmatively respond to each of the 5 elements. The first is whether the senior governing board places safety as a core value and whether it holds leaders accountable for safety, including the patient safety performance and how that informs leadership reviews and compensation. In the second area, and this is where we'll spend a little bit more time today, we're looking at whether C-suite executives place safety as a core institutional value and whether one or more of those C-suite leaders oversees a system-wide assessment on safety and execution of plans associated with what's revealed in that assessment and is able to share improvement plans and metrics across the hospital and with the board. The third element addresses whether hospitals are ensuring adequate resources to support safety. The fourth is whether reporting on patient safety and workforce safety events and initiatives account for at least 20% of all regular board agendas and discussion times. And the third is whether or not the C-suite executives and the board members are notified within 3 business days of any confirmed serious safety event. And this doesn't mean that they have to be fully explored and assessed and analyzed within those 3 days, but confirmed as events. There is, on the next slide, a little bit more guidance. And again, I can't see the chat quite right now, but I have a feeling that you're starting to see some resources being dropped into the chat that will help you understand some of the operational definitions and what this means. It is particularly built out for Domain 1, where hospital leaders are defined as the senior governing board and C-suite leaders, and this can include medical staff that are responsible for overseeing quality within the hospital. The senior governing board is defined as the body that has fiduciary responsibility for the hospital, that's in charge of resource management. They may or may not oversee other subordinate hospital boards. And in the case where there's no hospital level board, the governing body that is responsible for that individual hospital is the body that is relevant to what the structural measure is asking about. Domain number 2 focuses in on strategic planning and organizational policy, and this domain asks hospitals to attest to whether there's a strategic plan in place that publicly shares the commitment to patient safety as a core value and includes the goal of 0 preventable harm. And I can tell you, as you look at the comments that came in over the public comment periods for the structural measure, that this was one area where there was some differences of opinion on whether or not 0 preventable harm is realizable. However, the intention of having this publicly stated is the importance of having this be the daily aspirations that hospitals are constantly working toward, and this constancy of purpose to accept nothing less than 0 preventable harm. This domain also asks whether safety goals are including metrics that identify disparities in safety outcomes related to the populations that are served by the hospital. It also inquires whether hospitals have written policies and procedures in place around just culture. And it specifies that there should be a balance of no blame and appropriate accountability, and the distinction between human error, at-risk behavior, and reckless behavior. And I know that there's different, particularly in Massachusetts, there's different approaches that organizations take to this work, and that is very commonly reflected in the policies that exist now. The fourth statement is about whether the hospital requires a patient safety curriculum and competencies for all of their clinical and non-clinical staff, inclusive of the board and the C-suite, and whether or not there's regular competency assessment for all and action plans to continue to advance those skills and behaviors. And the fifth element is around whether the hospital has a workforce safety action plan that addresses both physical and psychological safety. The third area, is around the culture of safety in the learning health system. And the elements within this category focus on whether or not the hospital conducts an annual hospital-wide safety culture survey using a validated tool. If it's not done annually, but is done every 2 years, there's an expectation that pulse surveys on targeted units are conducted in the interim years where that hospital-wide survey is not done. And importantly, that it's informing interventions to reduce harm. It asks whether there's a dedicated team that conducts event analysis of serious safety events, whether there's a patient safety metrics dashboard and use of external benchmarks to help monitor and inform improvement activities. And on this eye chart slide, I know this is a hard one to read, the fourth statement asks whether the hospital is implementing at least 4 of the following high reliability practices. One is tiered and escalating huddles, and the structural measure is expecting that those are done at least 5 days a week with at least 1 weekend day, that they include clinical and non-clinical units and leaders, and that there's a method to follow up on issues identified. And that's one of the themes that comes out in the structural measure in a few places about whether or not there's a method to follow up on the issues that are identified. And you see that in the second of 7 high reliability practices, whether leaders participate in monthly safety rounding on all units, and whether this is happening with the C-suite at least quarterly. The third is whether there's a data infrastructure in place to measure patient safety and track the incidence of events and precursor events, and whether that is shared as part of the board meetings. Technology use, CPOE and barcode medication administration fall into that fourth high reliability practice. The fifth is around whether the hospital uses a defined improvement method or a combination of methods such as PDSA or lean or high reliability. The next is team collaboration and communication for all staff. And the final of the 7 high reliability practices that they state is whether or not use of human factors engineering principles is incorporated into the selection and design of devices, equipment, and processes. And these are all practices that are not necessarily new. The human factors one, for example, came out loud and clear 25 years ago, and we're continuing to encourage organizations to apply safety science and human factor science in their daily work. In fact, we just released a new course on human factors in healthcare and a new certification in that space because it's becoming increasingly important to help focus on that system improvement and the system design that Pat talked about in the introduction. Finally, and this is something that's associated even with this webinar that you're on today and with the wonderful work of the MHA, the statement asked whether the hospital is participating in large-scale learning networks for patient safety improvement and whether they are sharing data and adopting practices from the engagement in those networks and collaboratives. Okay, we got 2 more left to go. Let's talk for a minute about accountability and transparency. The statements in this area ask whether there's a confidential safety reporting system in place and whether it enables reporting not only of events, but also unsafe conditions and other concerns. And again, prompts a feedback loop to reporters, which has been especially important because we've been inviting, in many cases, people to report and encouraging that. And oftentimes what we hear is that our colleagues lose their incentive to do this because they're not necessarily getting feedback about the reports they've entered. The next is whether a hospital voluntarily works with an ARC-listed PSO, the Patient Safety Organization, to carry out their safety work. The third is whether patient safety metrics are tracked and reported and made publicly visible in hospital units, not just in a break room, but where patients and families and visitors can see those metrics over time. The fourth is around whether the hospital has a defined and evidence-based communication and resolution program that is reliably implemented. And they talk about ARC's Candor program, but I want to point out in the state of Massachusetts in particular, we've done some phenomenal work through the Betsy Lehman Center with the CARE program. And for those of you that want to learn a little bit more, they actually have their annual forum this Friday, and you can register to participate in person or virtually on that forum. So it's a really well-timed event on the basis of this conversation today. The final statement in this domain is also associated with a communication and resolution program, asking whether the hospital uses standard measures like time to resolution of any events that occur, and expects that those are reported to the board on at least a quarterly basis. The final domain is around patient and family engagement, and the statements in this domain are around whether or not there's a patient and family advisory committee that ensures input to safety-related activities, and that there's representation at board meetings, engagement in goal setting, and participation in improvement initiatives. So that input is especially important. And whether or not, in the second statement, the composition of the PFAC is representative of the population served. The next statement is around whether or not patients have comprehensive access to their medical records and clinician notes, and that it's provided in culturally and linguistically appropriate support for interpretation, and also that patients can submit comments for potential correction to their record. And again, Massachusetts, the birthplace of open notes, we've seen so much of this wonderful work now kind of more seamlessly integrated in what we expect in order to have in place for safety to be meaningfully realized and to support this co-production of safety with patients. There's also a statement around whether or not organizations, hospitals incorporate patient and caregiver input into patient safety events and issues. And this includes looking at complaints and experience data to surface signals that might be important, that have some indications that they could be associated with safety, and things like reports of discrimination. And many of you may be aware that ECRI put out their top 10 safety concern report just a couple of weeks ago during Patient Safety Awareness Week. And top on that list was dismissing patient concerns and feedback. So that's also another great reference to think about on this particular item. And then finally, does the hospital support the presence of family and other designated members as defined by the patient as essential members of their safe team? And are they encouraging engagement and activities such as rounding and discharge planning and 24-hour visitation as is feasible? So that's a quick drive through. I know there's a lot of eye charts there, but hopefully it brings you up to speed with what is in the measure. And I know some of you probably had this very well hardwired already. I want to take a few minutes before we open it up for discussion to talk a little bit about that National Action Plan assessment and how it links to Domain 1 statement around overseeing a system-wide assessment on safety. And that is clearly articulated in the patient safety structural measure content and background. It suggests that the freely available National Action Plan framework can be used to conduct that assessment overall. And this assessment has been in use now for almost 5 years by some organizations. It admittedly came out amid the pandemic, and we know that there were a lot of priorities that people had on their mind right now. So I'm not surprised to see that there's more opportunity to raise awareness of this. The assessment tool that we'll talk about in just a couple of slides was also recently updated. Well, it informed the patient safety structural measure. In December, there were some final tweaks made to it so that it's extremely well aligned with what you might want to do for your work in safety, whether you are subject to the patient safety structural measure or whether you work in an outpatient setting or a non-hospital setting. This is a tool that was designed for your ability to assess the strengths and the opportunities for improvement that you have. And now there is some very nice alignment, even more alignment, I should say, with what came out in the structural measure that was released in August. The National Action Plan actually focused on strengthening the systems for safety with a focus on 4 foundational areas that are threaded throughout the domains of the structural measure, including culture, leadership, and governance, patient and family caregiver engagement, workforce safety and well-being, and the learning system. And all of the components of the National Action Plan are freely available on the IHI website. The first component is the plan itself. The second component is that self-assessment tool that I've just described in a little bit more detail. And the third is an implementation resource guide. The self-assessment tool is available in both a downloadable format, or you can use the online format to assess your organization and see where you stand. The QR code should take you to that page. And this is an example of what the first element under culture, leadership, and governance looks like in that assessment tool, where we pull out this notion of goals and strategy. And what you can see is that you may find that you don't know a whole lot about whether or not this is included. There might be some patient safety goals, but they may not be clearly aligned in the operational plan. And over on the far right-hand side, you can see the integration of this notion of zero preventable harm that is now integrated into the assessment tool itself. So with that, we want to, before we open things up for discussion, invite you to tell us what you're currently thinking about where your organization stands. If this is applicable for you, what you predict your first attestation might reveal. And it may be that you meet some of the required activities for some of the domains. You may meet some of the required activities for all 5 domains, or you may be meeting most or all of the required activities for the domains. So we'll take a minute now to see where you might place yourself. Thank you for the one person who has responded. Let's see if we can get a few more folks sharing where you think you stand. Okay. I'm going to pause for a moment to see if we can prompt just a little bit more engagement and reflection of your organization's current state. Okay. So some of the required activities for all of the domains. Yes, thank you. I know for some this is not necessarily applicable. And we've got some who are feeling a little bit more confident about where you're currently standing, which is great to know. So with that, what I'm going to do, and you can keep voting on that, but it's looking like we're in at least most or all or some of the required activities for all domains. Pat, I think this would be a good time for me to stop sharing my screen and, open things up for discussion. And it'll be my first chance to see what's coming in with the chat. So thank you.
Thank you, Patricia, for this wonderful presentation, full of important information. We do actually have 5 questions that came through the chat. So I can start going through those, if that's okay with you.
Sure.
Okay. The first one is, do pulse surveys have to be validated tools?
It does not indicate to the best of my recollection, Pat, that it has to be a validated tool. But these can even be 5 to 10 questions on targeted units. And I don't believe that the validated tool was necessarily a requirement for that.
Okay. Okay, second question. What is your experience with the patient safety curriculum and competencies for all staff? And this person
Yeah.
explains, we are working on a workshop concept that will roll monthly throughout the year to catch existing staff and new staff.
Yeah. Yeah, I appreciate that question, Pat. This is actually one of the areas that I will say I think many organizations don't yet have in place. It doesn't mean that everyone in the organization needs to take the same, curriculum. There certainly can be variability, and this can be centered on what the important competencies are for the different colleagues around safety. So this is one that's a little bit more I think of a reach for many organizations based on the feedback that I've heard. And I will say as well too that I know in Massachusetts, and I think we might have some colleagues from the Betsy Lehman Center who are on the call. We've got some curriculum development going on that is ideally centered on helping advance and provide a tool that would be easy for organizations to turn to. And the reason why we're even asking this question, I think, Pat, is a good reflection on why the structural measure matters. Many folks will say, for example, well, we don't really have a standard curriculum for our board, for example. And we know that co-production of safety is really everyone's job. In the hospital, it's not just the many of you who are here on this call, I know work in quality and safety roles. But this is really amplifying, I think, the capabilities of the workforce writ large. So I would say that's one that is more of a reach.
Okay. Let's see. Next, is the care model an alternative to Candor?
Yes, and I don't know if we have anyone on the line here, from the care model. I think what's important to do is the patient safety structural measure will recommend they'll offer some examples of tools. So the Candor program, of course, was developed and is supported with our federal tax dollars through ARC. Yet it's important, it doesn't require Candor, and it asks whether the program meets, I think there are 5 criteria for that program. So long as you can attest to meeting the criteria that are in that communication and resolution program statement, then the tool should be perfectly applicable for you. And again, timeliness of the CARE Forum coming up this Friday for those who might want to learn more.
Thank you. Okay, this is a little longer question. Is there further guidance or criteria for what would constitute a serious event that requires 3-day reporting to the board? And then there's further explanation. Certainly, all SREs and other serious events get reported regularly now. Is this the new expectation that, for instance, a fall with a fracture needs to be reported within 3 days to board members?
My understanding and interpretation of what's in here, and again, I encourage you to take a look as well at the attestation guide because it provides a definition of what qualifies under a serious safety event. And my understanding and interpretation is that yes, that would mean that these should be reported to the board.
Okay, thank you.
And by the way, Pat, if it's okay, I want to have enough humility, for others on the call, who are attendees, to jump on in here with any perspectives that they have for any of these questions. Thank you.
Yes, great. And also, we certainly are looking to have a continued series on this topic and cover
Yes.
issues that are important to you, the audience, for each domain. So if you do have ideas about that, enter them into the chat, or please contact us at MHA at any time in the future. Okay, two more questions.
Sure.
Do you have specific guidance regarding the 20% patient safety requirement at the highest board level? Is that?
So, yeah, I think the best guidance that I can provide right now, and folks are looking, well, how do we assess this? Is like, what does the board agenda show? Quite frankly, how much time is allocated on the board agenda for discussions around patient safety? And, I know one of the related questions that comes up, Pat, for this one is, well, isn't this the work that the Quality and Safety Committee does? They go through all of the, details and look, under the covers, so to speak, at a lot of the metrics that are commonly used. And it doesn't mean that it should be repeated at the board. I think that, the work of the Quality and Safety Committees might be somewhat different, but there needs to be some visibility that's provided to the senior governing board and discussion around that as well. I think what I've heard from many organizations, that the best tracking that they're able to do on this one is to make sure that the board agenda is reflecting at least 20% of the time for these regularly scheduled board meetings. It does not apply to any special meetings that the board may convene at any given time.
Okay. And there is, so far anyway, one final question that I think is on everyone's mind, whether the new federal administration will actually support the PSSM measure, or will it be dropped as an expectation? And if the latter, what will happen to these important efforts?
Yeah, Pat. I wish I know, and I'll just let you know too, Pat and the MHA colleagues on the call, and I've talked about this because on a day-to-day basis, there's so many new things that we're learning, and there's an incredible amount of uncertainty that is out there right now about what might happen. The answer is no. I do not have a crystal ball into knowing whether this will change. We've received no signals from CMS that anything is changing at this time. We're monitoring all of these changes very, very carefully, and I know that MHA is doing the same. The question about what will happen to these important efforts, I think, is really an important one. And first of all, I think what we would hear if there was any pressure to remove the structural measure is a lot of advocacy from our patient and family activists and advocates that are out there who have been wanting hospitals and healthcare writ large to really improve the leadership and cultural and structural practices that are in place for safety. They know that these are clear opportunities for improvement, and realize as a result of their lived experience and through their ongoing work that we've got some gaps. And again, I know when we have webinars like this, Pat, we kind of are preaching to the choir of people that are deeply, deeply committed to this work. My reflections on what were to happen if the latter does occur is that I think it would be a significant setback for safety. I think that we will continue to see over time incredible variation in high-performing organizations that have really codified a lot of this attention to safety improvements in their day-to-day work versus organizations that perhaps have not. We know that safety is a system property, and we know that it's a real-time property. No matter what we have on our websites for leapfrog scores or star ratings, safety is realized in every ongoing moment of an encounter that a patient has with healthcare. And we can continue. I predict we'll be having the same conversations 5 years from now about the whack-a-mole approach that we take to dealing with surges in rates of healthcare acquired conditions if we don't spend more proportionate time focusing in on the strategic and the operational essentials that are required for safety to be realized. So I know that I bring a little bit of a bias, and I think you would expect that from where I'm coming from with this work, but I'm quite frankly sitting every year in brand new meetings about why aren't we like realizing safety? And it keeps coming back to a lot of these systems-based considerations for fortifying the conditions for safety to be realized every day and in every moment. Thank you for letting me be on that soapbox for a moment.
Thank you. Well, we don't have any other questions coming in. I'll pause for a moment to please encourage anybody else that has questions to please add them into the chat. And also just reiterate, that we are planning to continue this series in the domain specific areas. So if you do have areas in each of the domain that you want to learn about more or strengthen your organization more, or are interested in sharing your work, with us, and we can highlight you, please get in touch with us, or even enter your name into the chat and we'll be in touch with you. So I'll just go ahead.
One thing that I can share with our group, particularly based on the number of organizations over the years that have been using the self-assessment tool, is that the domain that appears to be most challenging for organizations is the patient and family engagement domain. And that, we know what happened during the pandemic, where we had to shift away from some of the in-person PFAC activities, and some of that got put on hold. But I did want to call that out as it's not 100% of organizations, but it is a fairly common denominator in the scores that we're seeing. And this is where a lot of folks are saying, boy, we really do want to get back on track with this patient and family engagement area in ways that maybe were extinguished a little bit over the course of the pandemic. And I would like to just note, as we wind things down as well too, and my screen sharing here may not be Nick perfect, but if you can see my screen here at some level, I did want to also just note, if you'll forgive me for any variation in how this screen shows up for you, that we have a number of resources, many of which are freely available through IHI. We've talked about a lot of other resources that are available today, but I also just wanted to make sure that you knew that this slide was in your deck. And thank you for all that you do every day to keep patients and the workforce that is so integral to ensuring patient safety free from harm.
And Patricia, there's one last question that got snuck in
Sure.
around patient and family engagement. Does the patient family engagement expectation get fulfilled by having a PFAC, or is engagement broader than that?
Yeah, that's a great question. Unfortunately, the short answer is no. Just having a PFAC does not mean that you are fulfilling the attestation statements in Domain 5. It is whether or not there is meaningful engagement and inclusion of the work of the PFAC in the production of safety within the system. So I really appreciate that that question came in, and I encourage you again to sift through the materials. Both Pat, I think you chatted in, and we'll be sending some things in follow-up. The specifications for the measure, an attestation guide. There's a one-page quick reference to the patient safety structural measure and more, but that will go into a little bit more detail, particularly that attestation guide on the PFAC requirements. Thank you.
Thank you very much. So we don't have any other questions coming in. So I do want to thank you, Patricia, for just a very information-filled presentation that was really excellent, and hopefully in a very engaged audience. Thank you, everyone, for all of your questions. You will be receiving these slides. We also have taped this, and so that will be available to you as well. And then at some point, this will also be posted on our MHA website under education. And again, please send us any questions that you may have, or any further, information you would like to learn about the patient safety measure and the specific domains. Thank you for joining us. And also you can scan the QR code on your screen now to learn about more of MHA's ongoing educational programming. Thank you, everyone, and have a great rest of the day.
Thank you.